Welcome to part two of our three-part roundtable discussion on current topics in Parkinson's disease. I'm Dr. Winston Wong, formerly from the payer arena and currently an independent consultant, and I will be moderating this roundtable discussion. For this series, we are joined by the following experts. Dr. Yasser Torres Yagi is the director of the Parkinsonism and Dementia Clinic at the MedStar Georgetown University Hospital. He's also the co-director of the Movement Disorders Fellowship at the Parkinson's Foundation's Center of Excellence and an assistant professor of neurology at the Georgetown University School of Medicine. Dr. Yagi will be representing the physician perspective. Dr. Patty Today Allen is the VP of Clinical Programs and Services at Welldyne. Dr. Today Allen will be representing the pharmacist perspective. Dr. Barney Spivak will be representing the payer perspective. On the screen, you will see the disclaimer and faculty disclosures for this activity. For part two of today's discussion, we will be taking a deeper look at the available treatment options, the challenges that develop over time, and how we should address those challenges. To begin with, what factors are most significant when developing a treatment plan?
As a subspecialist in movement disorders, it took about 34 years, including preschool, to finally become one. That's my joke, but it's true. You know, understanding the disease state is so important, especially when you put on your therapeutic lenses, right? So addressing issues and understanding what those issues are, and then trying to come up with a therapeutic solution, whether it be non-pharmacologic or pharmacologic, is really our goal. And so when we try to establish the best care for somebody, our goal is to first understand what it's like to be in one day or several days of a Parkinson's patient. And the way we do that really is by understanding how they feel from the moment they wake up to the moment they go to sleep, but then also not to forget that time at night when they are sleeping to see if there's any kind of return of symptoms throughout that time period. This idea that Dr. Spivak mentioned of understanding wearing off, the time in which our return of symptoms impair our ability to function or cause damage, cause some sort of negative impact in our life, understanding the duration of those episodes, when they happen, how tolerable or intolerable they are, how predictable or unpredictable these wearing off episodes are, is so important to how it is that we can now kind of think about our treatment paradigm. In 2021, there are so many different options. Oftentimes we have to think about, hey, what are we doing here? What's our next step, right? And I think underlying the top kind of upstream strategy is to first determine what a patient's day looks like, sometimes on a half-hour to 1 hour basis. We need to understand when our patients are eating, when they're waking up, when they're sleeping, if they're taking naps throughout the day. Understanding their day on an hour-to-hour basis in a diary format oftentimes becomes so very important to our ability to treat our patients. And so part of what we do with all of our patient encounters is actually teach a patient and a patient's care partner how to deliver and communicate that information back to us. Sometimes we have evaluations where we're simply teaching our patients how to understand their own disorder and how to detect their own wearing off, because each person's experience of wearing off can be different, and each person's experience of wearing off can vary from moment to moment. We can have one type of wearing off episode, for example, in the morning when they first wake up, which is called morning akinesia or morning off, that can feel a certain way. But then we can have an experience later on in the day that could be a non-motor experience. Maybe the tremor or rigidity or slowness of movement does not return. Maybe it's more anxiety or cognitive dysfunction that manifests itself during that off episode. So understanding the variability, educating our patients, having them communicate to us how they're doing, I think that's the first step in understanding how we can treat them.
I'll just add one thing to that is when you're trying to determine when those off episodes are happening, is really, you have to determine adherence, right? Because is it because the drug is no longer working and that's what's happening? Or is it because the patient thinks they took it and so they said they took it, but then they didn't actually, they want to make the physician feel like, I'm a good patient, I take it every single time, but that may not be reality, right? And so it's really important to really let the patients be comfortable in being truthful with their providers and with their physicians and their pharmacists about reasons why they may not be taking it. Because remember, that heavy pill burden, and it can be very difficult. That's several times a day, and having to document that can be very challenging. A lot of times patients just want to check out. It's a life altering diagnosis, and it's very challenging. It's really important to see that perspective, as Dr. Yahi was saying. We need to understand a day in the life, but we need to appreciate that day in the life is also very, very challenging. And there needs to be a lot of understanding about that, and to not come off as you're being authoritative or, mandating you need to take your medication, but more putting it in a using those motivational interviewing techniques to help them better, engage with that, and to be, want to kind of buy in to be able to take their medication. So that's what I wanted to add to that.
Okay.
I think it's also important to stress in a general sense, not only how the individual's Parkinson's disease is being managed or managing, but also, a little bit more about what context is that individual managing that disease within. In other words, what other conditions exist? What other chronic impairments does this person have that need to be addressed, whether it's by medication, whether it's non-pharmacologic approaches, both. Who's there to sort of assist that individual? What context of support exists for that person? In the home, outside the home? Many of these people with Parkinson's disease are, they're working, or they're trying to work, or they're trying to improve their quality of life by getting involved with activities with others. They're trying to improve their socialization. We need to understand, how are they functioning, and not only, who's around to sort of assist them if they do need help, but what are they trying to do, and how can we help them do it? So, are they driving? Are they swimming? When they may, have problems with some of the activities that they enjoy doing. Are they sleeping adequately? Are they getting adequate nutrition? Are they living in a setting that presents mobility challenges? For example, stairways, all the hazards that we can talk about in terms of what we know about in terms of fall prevention. Is there a simpler way for them to be living the life that they would look forward to on a daily basis? And as I mentioned, I think what matters most to them? What do they want to do that they are no longer able to do? And what can we do to focus them and the caregiving team on that specific objective that they have that will make a difference to them? For older adults, again, we often think of the 3M approach, right? So it's medications, as you mentioned. We talk about mobility, which obviously is the cornerstone of what we're trying to improve with this condition, and mentation, which again, as we said, can often be negatively impacted by the condition or by the treatment that we provide for it. So we need to really take all of that into account as we're trying to deal with this condition, and to minimize the impact that it has on the individual's well-being, quality of life, and health outcomes, basically. The last thing that we want to try to, what we want to try to avoid, hopefully, is having to have that individual leave their preferred residence. In other words, having to leave the home for some other care setting. So if we can try to minimize the risk of that and try to improve the caregiving, the non-pharmacologic approaches, specifically rehab approaches, getting them involved with exercise programs, for example, Tai Chi and other programs have demonstrated significant benefit for this population, we will have made a positive impact and improved the outcomes in general for the patient and for the population that's affected by this.
Another treatment challenge that I think about from a pharmacist perspective, and then also can be from a payer perspective, is really access to the medications and navigating the benefit from those patients. So I have this prescription. How do I go get it, right? How do I get it? Is it restricted to a certain kind of pharmacy? How do I go obtain it? And not necessarily maybe the initial therapies, but as we progress to some of the more advanced therapies, or needing surgery and all that, patients require some assistance in being able to understand their benefit and how to navigate that benefit as well.
Great. Well, you all three of you referred to, as Dr. Yagi put it, the wearing off period or the off periods. As patients start experiencing these off episodes, what's your thoughts on the approach that should be taken? Should it be like changing medications to, the primary medications to a different class that may have a different impact or effect, again, based upon what the patient is looking for? Or do you have a combination of on therapy and on-demand therapy to go and treat the off episodes? There's so many different ways I think treatments can go. Just wanted to get your thoughts on, what's your approach, or what should the approach be?
From a movement disorder standpoint, it is the answer is a very vibrant answer, and it's exciting, and traditionally, neurology may have been a field where it's very diagnostic in nature, but in 2021, it's a very therapeutically driven, therapeutically minded field. There are many therapeutic options. The therapeutic landscape, especially in Parkinson's disease in 2021, is expansive, as was mentioned before. So when we talk about Parkinson's disease, and to answer that question, we always need to remember that it's not always an or type of experience. Sometimes it's an and experience. You're not always making one decision at a time. It's a dynamic, oftentimes what we're doing is a very dynamic analytical process where we're trying to understand now that we have maintenance medications, we have our kind of gold standard of carbidopa, levodopa throughout the day. We have now adjunctive maintenance medications, which have been shown to reduce off time, improve that good on time. But then taking it a step further, it really shouldn't be a step further, but taking that step further and saying, well, what about these on-demand therapies now that we have in 2021? How do we utilize them? Where are they? Where should we utilize them in that treatment paradigm? I think utilizing the on-demand therapies on an individual basis, what's right for personalized care for each person, is very, very important. And the most important part of that is that detection of off, understanding when it happens throughout the day, and then being able to address it, not just with one therapy. Maybe sometimes we're thinking about two options. Now, we might consider a patient, say, okay, we're experiencing wearing off throughout the day. An on-demand therapy sounds like it is a very plausible treatment modality in this patient. So you might consider saying, okay, well, we have this on-demand therapy that we can utilize either in the morning or in between our doses of carbidopa, levodopa, sometimes in the middle of the night where our patients might wake up and feel like they've worn off of their Parkinsonian medicines. So these are ways that we think about utilizing on-demand therapies. But I think it's important when we talk about access, as Dr. Tade Allen was mentioning, a lot of the times with these more advanced therapeutics, or just therapeutics nowadays in 2021, how is it that we can get our patients on two drugs, maybe a maintenance therapy, but at the same time equipping them with an on-demand action plan to take care of their off episodes as they happen? I grew up taking care of my mother, who was a chronic asthmatic. So I still remember throughout my whole life living with her and traveling, going to see my grandparents over the holidays. She would take a suitcase just to take care of her asthma. She had her maintenance therapies, she had her on-demand action therapies. I mean, we know about this idea in all these other disease states. For Parkinson's disease, I think it's important to kind of appreciate the fact that we have on-demand therapies that can be utilized also with maintenance therapies, because the odds are in a patient that's experiencing wearing off, we can adjust maintenance therapies. We can use reformulation, extended release formulations of carbidopa, levodopa, dopamine agonists, maybe amantadine derivatives can be helpful. But odds are patients will need an on-demand action plan, regardless of what sort of medication adjustments you're doing or surgical treatment steps you're utilizing to help our patients with control of their symptoms.
So how do these on-demand therapies differ? As I recall, there are 3 products that are out there. From a payer perspective, is there equal access to them? From a pharmacy perspective, is there equal access? You talked about the difficulties of obtaining medications. Is there a differentiation here at all?
No, I think that the and I'm sure others will also chime in with their thoughts, but the 3 on-demand therapies have differences, but they're also similar, right? But the main differences is in how it's administered or how it's available for those patients. And in addition to that, when we're thinking about, remember, navigating the benefit, many of these medications may be considered a specialty or may be restricted to certain specialty pharmacy networks. So it's not something that a patient may be able to just go get at their local, community drugstore. And so that's something that can be very challenging for patients to even understand if they've never had a specialty medication in their entire life, what that means and what that process is like, and how that is going to financially impact them as well. A lot of these, some of these on-demand therapies, there's a wide range of costs associated with them. And especially if we're thinking about the Medicare population, there's some different significant cost shares that will impact patients where they may decide not to do it. They may decide that, yeah, this off period is really bothering me, but it's not worth this amount of money every month or every 3 months or whatnot. So, and you have to, as a clinician, you can't just say, well, that's not the right answer. You have to be able to work with that patient and try and provide, let's look for foundation help, see if there's any way we can do to help these patients. But if they choose that, my off period is not that bad, I can handle it, then you have, as a clinician, you have to respect those wishes, because ultimately that patient is the one who's in the driver's seat, right? They're the ones who are going to decide whether or not they're going to take that medication, no matter how much we want to tell them to take their medication or that this might improve their life. And so something that we need to, be cognizant of and to think about.
Dr. Spivak, you had a response?
Yeah, my sense, again, would be that we want to make available medications that may need to be tried on a trial, on a trial basis, because not everyone may respond to one of the 3 medications that is available, or one of the 3 choices. So, for different people, there may be different benefits with using one or another of these approaches, or there may be no benefit after the trial. So it's important to, I think, be able to give patients some flexibility in terms of, and their prescribers some flexibility in terms of choice, so that the appropriate choice for that particular patient can be obtained. Again, the focus is on trying to use the right medicine for the right person for the right reason, and prescribed by the right prescriber. Not only to take the medication at the right time and so on, as Dr. Today Allen mentioned, but we want to be able to provide medications that work, that have hopefully a added value to the regimen that the patient is already on, and that don't have a significant burden of side effect or administration difficulties that make it challenging for the individual who has a movement disorder to manipulate a syringe, or to, be able to use a inhalant properly, or to manage the use of these medications in the context of other chronic problems. For example, someone who has chronic obstructive pulmonary disease, or as Dr. Yagi mentioned, asthma, or some other reversible bronchospastic disorder, you don't want to use an inhaled agent that may be available for the management of these off episodes on demand. It's just not, not appropriate. Similarly, for someone who has significant difficulties, who may not have a caregiver available, may not have someone else to either provide the device or ensure that they're using it and being monitored properly. It may not be wise to use an injection at all, an injectable agent, the injectable apomorphine, as an example. For many people, again, we don't want to add something that's going to add a significant burden to an already complex disorder and complex management. And I think some of the disadvantage with some of the agents in this category relate to the need for very careful titration, very careful monitoring, very difficult to sort of institute in someone who may not be able to access a caregiver and be able to provide appropriate monitoring capability for that particular medication use. Also, some of the medications in this category and the ones that we're talking about for on demand may provide minimal benefit overall. It just may not be effective. On the other hand, there may be some that benefit significantly, and we need to find that out because whatever we can do, as Dr. Yagi had indicated, to try to improve the daily management of these individuals, to decrease those ups and downs, and to try to stabilize an individual throughout the course of a day and night. The more we can do to enable that, the better we're going to be in terms of providing appropriate therapy and appropriate support for that.
Great. Dr. Yagi, any last comments on the on-demand therapies?
Got it. I think what was mentioned is wonderful and very important information by Dr. Spivak and Dr. Today Allen. Those perspectives are very important from a clinician standpoint. Hearing their perspective is wonderful, and hearing that we all have a common goal and we all have a different perspective on that. You got it. When you think about on-demand therapy, I think we all have to appreciate why these therapies are in a class of their own, and the reason really is physiologic, right? Our Parkinson's patients, as we think about their kind of multi-organ involvement, the gastric dysfunction is something that we always, it's like a tide that our patients are constantly swimming against. And so why is it that we can't use more oral therapy or, try another oral therapy in an on-demand way to treat our Parkinson's symptoms? It's because of that gastric dysfunction. And so we have decreased gastric emptying, we have decreased motility of the esophagus, the lower GI tract, constipation, and our carbidopa, levodopa gets absorbed more readily in the lower GI system. And so our goal always is to bypass this gut dysfunction. And that kind of foundational concept is so important to teach our patients and to teach in general for everyone involved in making decisions, whether it be from access to the payment structure, to our patients themselves and the caregiver, why it is we're utilizing things like injections and inhalable medications, sublingual medications. The idea there is to provide a more reliable tool and help our patients in a reliable fashion get from an off nadir to an on kind of peak. Because how do we do that reliably and predictably? Oftentimes we need on-demand therapies, bypassing the gut so that we have a way to enter the blood so that then the medication can go from the blood to the brain in a more effective way, so that that time to on is more rapid, right? A patient might say, well, I can take my carbidopa, levodopa. Sometimes it takes 60 to 90 minutes before it kicks in. Sometimes it doesn't kick in at all. It's called the missed dose effect. It's like, I feel like I missed a dose, but I actually took my medicine. Our patients are trying sometimes to be very adherent to their regimen. Doesn't work. And so bypassing the gut so that that time to on in a reliable way might be faster, so that, within 30 minutes of taking a medication, we can get our patients out of danger, right? Understanding what sort of predicaments these off episodes put our patients in sometimes is very important. We have patients that unfortunately go from a hone and yar stage, as Dr. Spivak mentioned in his training, working with a very important figure, Dr. Yar, understanding your hone and yar staging. If you go from a stage 2, which means bilateral symptoms, to a stage 3, that means you're a fall risk. So if we're in an off state and we become, rather than be a hone and yar stage 1, which is just unilateral symptoms when we're in an on state, to a hone and yar stage of 3 when we're in an off state, that will create a negative impact. And so there is urgency to treat these off episodes, especially when you equip your patients and your patient care partners with that knowledge. Oftentimes that is a motivational tool for them to say, okay, how do I take that next therapeutic step with an on-demand therapy?
This concludes the second part of our 3-part roundtable series. In part 3 of our discussion, we will revisit the treatment paradigm and issues related to reimbursement. Thank you to our faculty for your insights, and a special thanks to our sponsor, Synovian, and to First Report Managed Care for making this video possible.